Assalamu alaikum and welcome back to Pete's Mentor. I am Dr. Atif Raza and today you will learn about the most important topic of neonatal emergency, that is approach to neonatal seizures. What if I told you that the most dangerous seizures in medicine don't look like seizures at all? In neonates, a gentle bicycling of legs, smacking of lips, or rhythmic eye blinking could signal a neurological emergency that demands immediate action. So, here we are talking about the neonatal seizure, which is totally different from pediatric seizures because they are usually subtle. Neonatal seizures might present with normal looking primitive reflexes, or you may think that this child is just dreaming or being hungry. So, lip smacking, bicycling of legs, blinking of eye. All these might be normal, but they can be a signal for neonatal emergency, that is neonatal seizures. Therefore, it is important to distinguish between typical newborn behavior like being hungry or dreaming and a genuine brain seizure. So, let's start. As we all know that neonatal seizures are one of the most neurologically urgent conditions in pediatrics. This is because every minute of uncontrolled seizure activity increases the risk of long term neurological injury and impaired brain development. So, here every minute or seconds are important because if there is neonatal seizures, they might lead to neuronal injury, which can lead to permanent brain impairment or damage. But as I have already told you that this is a challenge. The neonatal brain doesn't seize like an adult brain. If you miss the subtle signs as discussed above, you may miss the opportunity to prevent irreversible neurological damage. So, today we are deep diving into this ultimate masterclass on approach to neonatal seizures. In this video, I will cover pathophysiology, then how to recognize it, that is clinical recognition, then etiologies, which are timeline based, diagnostic workup, and step by step management. I will discuss all these topics based on Nelson textbook of pediatrics 22nd edition, current diagnosis and treatment of pediatrics 27th edition, Gomella's neonatology 8th edition, and Osama Naga board review latest edition. So grab your pens. Now I am starting this with the pathophysiology. So first one is pathophysiology. First, let's understand the why. Why do neonatal seizures look so strange compared to seizures in older children? So, starting with the question, why do neonatal seizures are different? As we all know, the neonatal brain is structurally and functionally immature. Functionally and structurally not properly developed. Brain myelination is not complete, that is, there is incomplete myelination, immature synaptic connections, poor cortical organization. But the most important mechanism is an excitatory inhibitory imbalance. In the neonatal brain, GABA, which is an inhibitory neuron, is functionally immature and may even act as excitatory. GABA is inhibitory, which is immature, and NMDA glutamate receptor, which excite the neurons, are highly expressed. So, there is imbalance between the excitatory and inhibitory. So, NMDA receptors are highly expressed. This results in more excitatory signals as compared to inhibitory signals, and this results in hyperexcitable brain. Because of this hyperexcitable brain, a small metabolic disturbances like hypoglycemia or hypocalcemia can trigger seizures. So, in neonates, true generalized tonic-clonic seizures are extremely rare. It means they don't express generalized tonic-clonic seizures. This is because the cortex is not fully interconnected. As the cortex are not fully interconnected, electrical discharges cannot spread across both hemispheres efficiently. So, because of this reason, we rarely see true generalized tonic-clonic seizures in neonate. So, neonatal seizures are typically focal, subtle, or fragmented. So, as we have know the pathophysiology, how we can recognize is this a true seizure or is this a mimic. So, next part is clinical recognition. In between true seizure or mimics. So, before ordering a large workup, the first question is this actually a seizure? Neonates commonly show non epileptic movements, including jitteriness, tremors, and benign neonatal sleep myoclonus. So, we have to decide either this one is a true seizure or mimics. So, if an infant is jittery, it can be distinguished on the basis of clinical findings. So, jittery movements are basically stimulus sensitive. If you look at the jittery movement, usually they worsen with noise or touch. And one important point, if you gently hold or flex the limb, the shaking stops immediately. So, jitteriness usually stops while we hold the limbs. Also, one important point, if you are recording EEG, jitteriness has no EEG correlation. But if you look at a true seizure, true seizure does not stop with the resistant. It means if you hold the limb, if it is true seizure, it remains seizing. So it does not stop on resistant. One more point, true seizures often show abnormal eye deviation or staring. So they may have abnormal eye movements. Third and the most important, they have autonomic instability. So they show sign of autonomic instability like tachycardia, hypertension, or might results in apnea. So it is important to recognize the normal jitteriness with the true seizures. The best clinical approach is to hold the limbs. If it is jitteriness, the movement stops. But if it's true seizure, it remains in the same form. Once you determine this is a seizure, the next question is what type of seizure is it? So next is classification, that is what type of seizure is it? According to Nelson and Wolf Neonatal Neurology, neonatal seizures are classified into several clinical subtypes. The first one is subtle. So starting with this, subtle seizures. These are the most common overall, particularly in premature infants. More common and especially for preterms. For subtle seizures, you should look for lip smacking, chewing motions, bicycling leg movements, or any movement like swimming. These movements can look almost purposeful, which is why they are often misdiagnosed. So, these seizures are usually might look normal behavior of a neonate, but you have to identify this. Second one is focal clonic seizures. These are rhythmic jerking movements, and these jerks are usually 1 to 3 jerks per second. These are the most common seizure type in full term infants. Interestingly, the infant may appear fully awake during the seizure. Third one is focal tonic. These involve sustained asymmetric posturing of a limb or trunk. So here is sustained asymmetric posturing of limb or trunk. The fourth one is myoclonic seizures. These are rapid lightning like jerks. And these are commonly associated with severe metabolic disorders or early myoclonic encephalopathy, and unfortunately carry a poor prognosis. So they are usually associated with severe metabolic pathways issues or early myoclonic encephalopathy. One important point, up to 80% of the neonatal seizures may be electrographic only. It means they can be detected only by EEG. So, up to 80% can only be detected by an EEG. This is why EEG monitoring is absolutely essential in neonatal seizure diagnosis. Now, after the types of seizures, let's dig out the etiology. We have divided the etiology on the basis of timeline. So, in first 24 hours, usually the most common cause is hypoxic-ischemic encephalopathy, accounting for 40 to 60% of neonatal seizures. These infants often have, most common is HI, and these infants are often have fetal distress, low Apgar scores, and they need resuscitation. In first 24 hours, the most common, that is 40 to 60%, is due to HI. But you can also consider intracranial hemorrhage, birth trauma, and early sepsis from group B streptococcus or E. coli. These are not more common, but you have to consider this as well. So, intraventricular hemorrhage, birth trauma, and early sepsis. Next, we have a timeline for 24 to 72 hours. If a neonate starts seizing in between 24 to 72 hours, that is after first day of life till third day of life, think vascular or metabolic. Vascular usually include neonatal stroke, which often involves middle cerebral artery territory, that is MCA. Intraventricular hemorrhage in premature infants, and the third one in vascular is subarachnoid hemorrhage. For metabolic, always think for hypoglycemia, hypocalcemia, hypomagnesemia, and hyponatremia. All this can lead to seizure. After 72 hours of life, think for infection. So here infections are most likely. Infections can be HSV encephalitis, torch infections, here you can also consider inborn error of metabolism. Inborn error of metabolism often appear after feeding begins, and the red flag laboratory clue is increase ammonia, which is usually greater than 150 micromole per liter. Genetics are also involved in neonatal seizures. A classic board question: if a healthy term infant develops seizures around day 4 to 6 with a family history of neonatal seizure, then you should think for benign familial neonatal seizure. These seizures are autosomal dominant and is caused by mutation in potassium channel genes, which are KCNQ2 and KCNQ3. Most importantly, these seizures have a good prognosis, and most infants stop seizing by 2 to 6 months of age and have normal development. So, diagnosis is important over here. If you have a neonate presenting to you with a family history of neonatal seizure, think for benign familial neonatal epilepsy. Now, after this, we should have a basic approach to diagnose all these conditions. So, we have a diagnostic approach. We have organized the workup into four diagnostic buckets. First one is bedside. So, on bedside, always check a stat glucose. If it is below 40 in an asymptomatic or below 45 in a symptomatic neonate, you should give 10% dextrose. So, first we have to check stat glucose level. Now, the second one, we send labs, and in labs we check for electrolytes, we check for ionized calcium, we check for magnesium, we check blood gases, and remember, also send ammonia and lactate for metabolic workup. We should also send CBC and CRP of this neonate. Third is for sepsis workup. For sepsis workup, we obtain cultures from blood, from urine, and from lumbar puncture, that is CSF. Remember, neonatal seizures must be considered infection until proven otherwise. Always send HSV PCR because HSV encephalitis is devastating but treatable. So, you should also send HSV PCR. Now, the fourth one is neurodiagnostic. First one is stat glucose, second one is laboratory investigations, third one is sepsis for sepsis, and fourth one is neurodiagnostic. Remember, in neonates, MRI is the most important and diagnostic imaging for any type of seizure. But you can also have cranial ultrasound to detect any type of bleeding. But remember, MRI is gold standard. One more, continuous amplitude integrated EEG is required to diagnose neonatal seizures. So it is essential for neonatal seizure to have amplitude integrated EEG. Now, after all this, that is the pathophysiology, clinical recognition, timeline based etiologies, diagnostic workup. We now dealt with stepwise management. So always remember, for stepwise management, we always start with A, B, and C. That is, we have to maintain airway, breathing, and circulation first. While doing so, you should also correct temperature, oxygenation, and electrolytes. Now, the second step, treat the reversible causes. So, for reversible causes, just like we have, if you have hypoglycemia, we should give 2 ml per kg of 10% dextrose. For hypocalcemia, we give 10% calcium gluconate and the dose is 1 to 2 ml per kg. After the reversible causes, we have anticonvulsants. First line to treat seizure is phenobarbital in neonates. So in neonates, we have first choice of phenobarbital, which is the first choice in neonate, and the dose of this is 20 mg per kg, which is a loading dose. But remember, phenobarbital can cause respiratory depression and its maximum cumulative dose is 40 mg per kg. If the seizure not settled by phenobarb, the second line therapy, which is increasingly preferred agent due to its safety profile, is Lirase, that is levetiracetam. The loading dose for it is 40 to 60 mg per kg. Alternatively, you can use phenytoin or fosphenytoin. And its dose is 15 to 20 mg per kg. But if the seizure is still not settled by using all this, you can use midazolam infusion for refractory seizures. Remember one thing, if seizure remain refractory, administer a pyridoxine trial. So remember one thing, if after doing all these and the seizure is still not settled, give a trial of pyridoxine. And the dose for it is 50 to 100 mg IV. But remember, always administer under EEG monitoring and be prepared for apnea, which can require ventilation. Pyridoxine basically treat pyridoxine dependent epilepsy. So this is for pyridoxine dependent epilepsy. One important point, as we have discussed, in preterm infant we have the most important cause is HI, that is hypoxic-ischemic encephalopathy. So for hypoxic-ischemic encephalopathy, remember we should start therapeutic hypothermia, and this should be in the range of from birth to 6 hours of life. So we have a special treatment, that is therapeutic hypothermia for HIE, and it should be started within the first 6 hours of life. Therapeutic hypothermia reduces mortality and long term neurological disability. So, we have done all the basic points of neonatal seizure. This is a detailed video. I hope that you have learned this basics of approach to neonatal seizure in detail over here. So, to summarize this lecture, first we have to distinguish between true seizure and the jitteriness. Remember, true seizure does not stop while we hold the limbs, while jitteriness stops after holding the limbs. Second one, if you have seizures between the first day of life, that is 0 to 24 hours of life, this is mostly due to HIE, that is hypoxic ischemic encephalopathy. Second important point is, if a seizure is between 5 to 7 days of life and there is a family history of neonatal seizure, think for benign familial neonatal seizure, which is autosomal dominant and due to mutation in potassium genes, that is KCNQ2 and KCNQ3. Always check for glucose because it is treatable. First drug of choice is phenobarbital, which is 20 mg per kg. And remember, many neonatal seizures are electrographic only, so continuous EEG monitoring is essential. Neonatal stroke is a major cause of focal clonic seizures. So for focal clonic seizure, think for neonatal stroke, which often involves middle cerebral artery. And one more thing, if you have done all the basic management but still the seizure is refractory, give pyridoxine trial. If seizure stops, it means we have pyridoxine dependent epilepsy, which is caused by mutation in ALDH7A1 gene. ALDH7A1 gene, leading to deficiency of active vitamin B6 cofactor. In the last, I have a question for you. Which congenital torch infection is most classically associated with periventricular calcification and neonatal seizure? So, question for today's lecture is, which torch infection is related to periventricular calcification and seizure? I hope you will comment this in the comment box. Still, if you have any query, you can ask me in the comment box. Inshallah, in the next video, I will discuss in detail, just like this, approach to neonatal jaundice. If you didn't subscribe my channel, subscribe to my channel, Pete's Mentor. Till then, Allah Hafiz.